So hello, my name is Ben Newton. I'm the General Manager of the Global Oncology Solutions business at GE Healthcare. And it's my pleasure to moderate and host today's session, today's Choose to Challenge session on Women's Health Day. You're probably wondering why this guy is moderating this special session on International Women's Day. Well, it's my pleasure to be able to tell you I'm really excited to be hosting and working with this phenomenal group of healthcare leaders from St. Luke's University Health Network, the Premier Applied Science Consulting Group, and of course, GE Healthcare. So let's start by asking a few questions, and questions hopefully you'll get to hear the answers to as we go through today. First thing is, do you know how many years of experience these women collectively bring to pushing the boundaries of healthcare? Keep that in mind as you hear some of their answers. Also, do you know who used to be an opera singer before she got into healthcare? Well, we'll be excited to reveal that in a few moments as well. And finally, who amongst these women is the licensed occupational therapist? Well, you're going to find out answers to all of these questions in just a moment. But look, the truth is, we talk every week, not only with this phenomenal group of leaders, but to all our colleagues about the theme that we're talking about today on International Women's Day. That theme is Choose to Challenge, and we've accepted the challenge, and I'm very pleased to say that these leaders have also accepted the challenge of appearing on this program to talk to you about choosing to challenge as well. So they've accepted the challenge to push women's health and healthcare beyond today's boundaries, and hopefully you're going to hear a bit more about that in the context of the work that we've done on the one-stop clinic for breast care. We're trying to push the boundaries around the standard of care in terms of time to diagnosis, in terms of time to treatment, and engineering that care pathway to become, hopefully, what is a desperately anxious time into something of the best possible experience. So with that, I'm going to share perhaps a little bit of context on the one-stop clinic before we start. Some of you will be aware of the Gustave Rossi's work in Paris, where Dr. Suzette Delaloge invented the concept of rapid diagnosis in the one-stop clinic. And we partnered with Gustave Rossi to try and internationalize that one-stop clinic, internationalize speed to diagnosis and time to treatment in just a single day. And since internationalizing that, we've managed to open a one-stop clinic in Colombia with Medellin, part of the Sura group of hospitals. We work closely with Dr. Sebastian Diaz and Ana Maria Sierra Acosta and their teams to not only diagnose and treat in a single day or start treatment in a single day, but also to screen patients more effectively and have a seamless route into that diagnosis in Colombia as well. And with the work that we'll talk about in a moment with Roni at the Premier Group, we introduced the first US one-stop clinic with St. Luke's as well. And it's my pleasure to be able to bring Michele into that discussion as well. So without further ado, let's get into the discussion. I'd like each of our leaders here to introduce themselves and maybe give us a little bit of their background and their role in their organizations, and then we'll get into the discussion proper. So let's start with you, Celeste. Celeste Slade. Tell us a little bit about yourself and what you do.
Great, thanks, Ben. So Celeste Slade, I've been with in medical imaging for over 20 years now. I've had the opportunity throughout my career to really see mammography grow from a film-based technology into digital to new standards of care with advanced applications like tomosynthesis and automated breast ultrasound, getting better access to MRI for women, new technologies like contrast enhanced, where we can have better access, again, breaking down barriers physically or financially for women and still getting that advanced care. I think the piece that I have really seem to grow and that we're trying to focus on more at GE Healthcare is that patient experience. So we know 50% of our women are not getting their mammograms. And if we really want to affect clinical outcomes, we have to get those patients into the system, doing their screening, and then staying in the system for those diagnostic workups as requested. So those are things that we're focusing on. We've redesigned the gantry by women for women, so what fits a woman better and is more comfortable. Things like patient experience, change the environment within which we're performing these exams with Sensory Suite, or a great technology like Duetta, giving the patients and women the control and be part of that exam. So all of those things are making a difference, and that's where we're focusing on. And it's been a great career and a great group of women to work with to see how we can make those changes.
Fantastic, Celeste. Thanks for the introduction and the background. We're going to come to, I think, many of those themes that you touched on in just a moment. So next, I'm going to move to my right on the screen here to Roni Christopher. Welcome, Roni. Great to see you as always. Tell us a little bit about yourself and your journey at Premier Applied Sciences.
Thanks so much, Ben. Really great to be on this event with all of you. Really, spend a lot of time with these colleagues on the call here and enjoy every minute of it. So I'm the Vice President of Design and Implementation for Premier Applied Sciences. And in that role, I lead an esteemed group of experts who are very skilled at quality improvement and rapid cycle testing, expert in understanding evidence, understanding and interpreting guidelines, and creating curriculum that help people make change. I've been at Premier for about 4.5 years, and prior to that, spent many, many years in large health systems across the United States, academic health systems. And this project is really near and dear to me and the team because we recognized that the work in France was really amazing, but there were some inhibiting factors here in the United States, some guidelines that didn't support replicating it as it was. And so we took the opportunity in Applied Sciences to work with our industry partner and our member partner to be able to say, how can we, not wait for guideline change, but instead look for an opportunity to influence a change. It was really easy to partner with GE on that because of the existing model and just the interest in trying to be innovative, all the things that Celeste said. And then it was great to be able to look across our membership and find a really early adopter in this space in St. Luke's Health Network. So we are really excited to be able to kind of help disrupt and bring to the US a challenge that says, hey, all women need the opportunity to be able to get a rapid diagnosis so that we can really start to manage breast cancer effectively. And we recognize that equipment really serves a role on the care team. It's not just a thing, it's not just diagnostic, that it really is kind of a part of the care pathway in a way that FTE is. And that's been some of the great insights that we have found in this project.
Oh, thanks so much.
That's occupational therapist, by the way.
Oh, sorry, I didn't mean to interrupt you. I just your passion and comes right through. And look, everyone who's listening will hear more about the innovation that Roni and the Premier team have brought to this. As she said, changes need to be made, some adjustments, and working with St. Luke's University Health Network has really brought everything to life. So in that, or with that, I should say, let's move to Michele Giletto. Michele, pleasure again to have you on this. And tell us please a little bit about yourself and your journey at St. Luke's as well.
Thanks, Ben. It's so great to be with everybody this morning. We are just so excited to be a partner with this project. My name is Michele Giletto. I'm the Network Director of Women's Imaging at St. Luke's University Health Network. And I've been with the network for about 11 years now, and I've been in this role for about 7. What a joy to be able to lead the women's imaging department at St. Luke's. St. Luke's has always been an early adapter of innovation in not only technology, but also in workflow. And everything that we do comes down to a core philosophy of, is it going to reduce the woman's anxiety? That has been our guiding light since the beginning. And as a result of that, I love this choose to challenge theme for today, because we are constantly holding ourselves to a high standard with regards to quality, patient experience, and turnaround times. Celeste mentioned Sensory Suite and Duetta, these things that are, it's a huge contributor to reducing the woman's anxiety and giving her a little bit more control to be a participant in this process, as opposed to things just seeming to happen to her. My background has always been in business. I'm not clinical by profession. And I've loved St. Luke's has given me this opportunity to lead this charge, primarily because what I contribute at the highest level first is I'm a woman, I'm a patient. And so we're always able to kind of get into that mindset because I can't bring a clinical excellence or a clinical acumen to the conversation, but I always have that patient first mindset. And my team has been so great, and they've taught me so much over the years that the clinical acumen has followed. But at the heart, it is all about the patient. I am actually, with my storied past of business, I'm also the opera singer among us. And no, I will not be letting out a high note today. But that was my first career, was actually as a professional singer. So in opera throughout Europe, mostly Austria. And then, you jump from that to cruise ships. So, there's been a lot of experience, a lot of life experience that I've been able to bring to this role. And this group has been so incredible to work with, and such a privilege and a pleasure to be working on this particular initiative, which is near and dear to my heart.
Fantastic, Michele. And when we learned about your background, moving from leading the stage to leading business to leading women's health, what a journey. And it is indeed a pleasure to talk to you. And thanks for the introduction. So I'm going to come back a little bit to this point around choosing to challenge. And Roni, if you don't mind, I'm going to put you on the spot, because actually, when we talked about the challenge of rapid diagnosis, the challenge of one-day diagnosis, and bringing that to the US, it was you and your team that really took up that challenge as partners with this. Tell me a little bit about how you looked at this, because going from diagnosis to biopsy and the results of that biopsy in the US has an approximate turnaround of about 21 days. How did you feel about that statistic, and thinking, how on earth are we going to meet the challenge of doing this in a rapid context? Can you share a little bit about what that means to you, and elements of that you'd like to share with the customers listening today?
Yeah, absolutely. And thank you for the opportunity to share it, because I think it's such an important part of this story and is applicable to any problem we try to solve in healthcare, to be frank. So at Premier, we have an amazing healthcare database, and in it, we are able to understand where we have, turnaround times, where we have response times. There are certain things we can start to identify across the many members who contribute to that data set. And in the analysis, we were able to confirm what literature does say, and what you said, Ben, is that the turnaround time is sadly and woefully lacking for screen to diagnosis. And so when you look at, in any typical healthcare challenge, you look at the evidence, you look at where people are doing something better, and you turn to France, who has an amazing model. And they have some guidelines that support that model to be able to do a one-day diagnosis. And it would be very easy in the United States, and probably has been for many years, to say, well, we can't replicate that because our guidelines here don't exactly match up, which is true. But that doesn't mean that we can't innovate, and it doesn't mean that we shouldn't try, and it doesn't mean that we can't think about building off of existing evidence to create new evidence using real world evidence tactics. That's where improvement science really helps us kind of break through and think about, what are we trying to aspire to, and how close can we get in any confounds that we have. So in the work that we did with, Celeste and Michele and the whole team, the work that we did to try to design processes where St. Luke's could really take what was a much better than national average at the time, really averaging around 11 days, and sometimes much better than that in their current process. We really challenged them to say, hey, how low can you go? And because they have an appetite for this kind of work, they are, Dr. Russo, who's the lead radiologist there, will say, we'll do the best we can, and we dare anybody else to chase us because we'll chase you back. And so fostering that kind of, internal, be the best you can, energy and initiative, and giving structure to it using existing evidence, but also putting some processes that help you test innovation and allow you to fail fast but recover quickly. Those kind of methodologies really help us get to putting something like this out there. So St. Luke's has had amazing progress here with, in light of a different guideline, but they were able to say, we'll do it. And they really are willing to say, we challenge anybody else to do it as well. And this is just about all women being able to be put through the right process to get their diagnosis as quickly as possible. Whoever you are, whatever you're facing, get you into the right process so we can get you the diagnosis as quickly as possible.
That's awesome, Roni. And I'm going to, Michele, come back to you, because effectively you and the St. Luke's team were put on the spot. Tell me a little bit about your thoughts around this choose to challenge, because although that 21-day turnaround is a kind of national average, St. Luke's was in a pretty good spot relative to that 21 days. But even St. Luke's wanted to actually improve further. Can you tell us a little bit about the challenge that you saw in moving even the St. Luke's network to a different level?
Absolutely. We have had an 11-day goal as our turnaround time from screening to pathology. And typically, the delay there is going to be between diagnostic imaging and biopsy, or screening to diagnostic. You're trying to work with a limited schedule. St. Luke's is in an enviable position for a couple reasons to have partnered on this project. One is that by the nature of our network, we are in a semi-urban and urban and rural environments. So we're able to even see within those types of communities and regions how it impacts the turnaround times. One of our goals has been to utilize our fellowship-trained breast imagers throughout the entire network so that they're actually traveling to some of the rural sites to do diagnostic imaging. But to do that, you can only do it one day a week. So what are the turnaround times for those? You might think some of those sites could be an extended turnaround time, and some of them are. Another site, our turnaround time in that environment is 3 days, because we're already starting to adapt this one-stop methodology. And our goal, as I said, is always to reduce a woman's anxiety. And in my mind, I think if we can take her to screening to pathology rapidly, and not over a weekend where she's worried about this and obsessing about it and not sleeping and having all of the anxiety and stress, which brings other health issues. That's our goal. So we've always been chasing that turnaround time. We had started to talk about a year prior about what's the next step for us. What are we going to be able to do? And the idea of increasing same day add-on biopsies, early identification of those high-risk patients. And how do you do that through IT, because you're not calling a BI-RAD 0 off of a BI-RAD 5 off of a screening. You're making a BI-RAD 0. So what are the aspects of doing that? And you really need the leadership support, the IT support, and certainly physician champions to help further this idea of really decreasing the turnaround time.
And that's awesome, Michele, because actually what we see here is Roni's team, supporting the re-engineering, if you like, of the care pathway, but frankly, you and the St. Luke's team reducing it to practice and really showing the way as to how it can be done in those compressed timelines. I'm going to come back to Celeste, actually, because Celeste made a really important point around the patient experience. Mm-hmm. Celeste, just in terms of the experience, you mentioned a few things that you've been focused on with the GE team around advanced applications, low-dose TOMO, and other technologies. In fact, Michele alluded to this around IT and so on, supporting and sustaining that improved care pathway. Can you share a little bit about some of the technology and some of the things that you're doing from the equipment and from the infrastructure piece, if you like, to enable a better experience and greater satisfaction with that journey?
So both Roni and Michele made great points around, getting a patient from that screening to biopsy. And every point along the way that we either have to move that patient to a different facility or spend another day or another 21 days until we get results is an opportunity to lose that patient. So I think from a manufacturer's perspective, how do we get those advanced technologies to the rural places, to the semi-urban? And that's where I think like contrast enhance comes into play. It breaks down physical barriers for women. It's very easier, I'll say, for facilities like St. Luke's to implement. We certainly need all the advanced technologies of the TOMO and MR and ultrasound and contrast enhanced. But Roni mentioned it's a personalized imaging approach. So getting those right technologies so that we're not losing those patients. And financially, we can do that more quickly for patients and really provide those opportunities there. I think the other piece that Michele mentioned was the IT. It's that workflow. We need to get images and the information, the risk models, the genetics, the pathology, all in line. At GE, we have a great opportunity to do that. We have the technology, we have the infrastructures. I think as we think of this choose to challenge, as a manufacturer and a woman, it's a little frustrating to know that we have the technologies. We know the science behind getting pathology back. Even with our US standards, that pathology can come back in 16 hours. So how do we get rid of that time between so that we're getting those results to the woman? So we know the science, we have the technology. It's a matter of challenging ourselves of what is that standard of care and if it's okay.
No, thank you, Celeste. And that challenge and reduction to practice, Michele, I'm going to ask you, maybe put you on the spot a little here, and with the question, what has been the biggest challenge, I guess, in taking up that choose to challenge task, I guess. What has been the biggest challenge in this journey? Because it's taken some time. It's not been easy, right? To take a model and to tailor it and to look at how it can be adapted into these rural and semi-rural and kind of urban settings. Is there one thing that you found or the team has found to be a big challenge in adapting into the kind of US model, so to speak?
Well, yeah, the obvious is we're doing it during a pandemic. So staffing and page, that's been a real challenge. But that's the obvious one. Beyond that, it's, we've had the support, we had the infrastructure. Dr. Russo, back in 2014, we started this idea of individualized breast care, that everything we did was looking at each patient individually, which plays into this beautifully. But for us, the real challenge is right now scaling it, right? Taking it to that weekly or presence, all day long, every day, all hands on deck, every room running that one-stop experience. So that's Obviously, that feels like the biggest challenge right now because that's the part of the process we're in right now. But that is a challenge. And the other thing you always want to watch too is the one-stop model for a system like ours, where, as I said, some of our sites are turning around normally 3 to 5 days. We have other outliers that are 14 days or higher. But on the average, we're, 7, 8 to 11 days. So you don't want to get into a mindset where, well, the one-stop day is on Monday and that's when we're doing it. And now that patient is longer to that care because she was a BI-RAD 0 on Monday. So now she has to wait till the next Monday. So we're looking at how to adapt the whole model, but for almost every patient throughout the work week. So that's another challenge because we don't want to delay her care to give her the one-stop experience. So that's been something we have just kind of recently stumbled upon.
No, thank you. And, I wasn't going to mention the P word, the pandemic word, but you're absolutely right. Look, I mean, early diagnosis, fast diagnosis and treatment has always been an issue in cancer, but Roni, it's being brought into sharp focus. We've seen huge falls in screening, and that has not been a good thing. Screening, of course, gives the opportunity to detect cancer early, which has a dramatic impact on outcomes. There's never been a better time, I guess, to implement these kinds of rapid diagnosis models, I guess. Never a more important time, I guess, because of the challenge that we've had over the last year and probably will have for a year or two to come, given the kind of backlog in screening that we've seen. What's your reaction to that?
Yeah, no question. Everybody is struggling with how to handle this, how to stay in front of a patient who all of a sudden gets concerned that they need access to care, but that getting access could also put them at risk for something. It's a very weird sort of mental kind of game that we all have to manage as patients, as consumers of healthcare, and as healthcare administrators and clinicians. I think for us, putting this work in our framework, the methodology that we use that we call the 3 I's, where we're trying to focus any process change around identifying the right patient population who needs the intervention and the people in your health system who need to understand why they should be focused on these kinds of outreach in a timely way. That's really important. Knowing how to intervene when that patient is in front of you, but also intervene to build skills among your staff. So we're constantly going back and forth. What are you doing at the patient level? What are you doing at the system level so that you don't have to panic about a pandemic? Once we get over the, true panic we all had to go through, you don't have to panic anymore about what you're seeing. You can be purposeful and planful about making sure that you get people, attached to the right care at the right time. But you have to have structure to do it. And that's what this project really helped us pull together. And then the third I of that is interact. And it's really, how do you create an environment where the patient comes into your system and feels safe, feels like they need to prioritize their care, that your providers from the radiology team, the imaging team, all the way to the oncology team, scheduling, and everything in between, everybody knows how to talk to that patient. And so that it feels kind of seamless to the patient, that they're getting a full-blown experience for something that they shouldn't put off, that they need to be diligent about, and that they're really cared for, not just given care, but they're cared for as a person. And so that I think that, Michele and her team and many of our other, premier hospitals have recognized that people are putting off care, but it feels anxiety inducing to say, how do we get to them? How do we think about it? How do we encourage them? And putting those things in a framework, like testing, trying, and then really getting it locked down. These are the things you do, get your processes in place, diligently work them. You'll find the patients, you'll get them in, you'll start to tell the story, and you'll see it start to evolve much more quickly. And I think that's really how you have to think about it.
I thought that was fantastic, Roni. So what you're telling us, a few more P's, right? You're saying don't panic, don't put off getting screened anymore, do some purposeful planning, and things will be all right. So I love that. Absolutely. we don't have to worry about peas anymore. So that's terrific. So in that context, Celeste, I want to come back to you around innovations and latest trends, because as well as these changes on the ground, so to speak, to improve and expedite the care pathway, there's lots happening in terms of innovation, clinical technologies to support even greater precision. So with women coming in, getting screened, getting investigated, there are some new technologies out there, right, that are helping drive precision around the diagnosis and treatment plan as well. Can you tell us a little bit about some of those advances?
Sure. So there's a number of a pathway, right? So we need to identify which women need which technology, whether it's based on their breast density, what their background risk is. We're learning so much more about genetics and those types of information about women and how we take them along that pathway. So, tomosynthesis has now been in the industry over 10 years now. It is becoming, more widely available. We think everyone has it. Not everyone has it yet. But we do see a clinical advantage. It is reducing those recalls. So women not having to come back, being able to clear them of a normal mammogram, being able to, understand where there are gaps in mammography, and we can use ultrasound and really educate women about what their density is so that we're not missing cancers. So getting that knowledge out there, not only to the women to understand that, but also to the physicians so that they do understand the need for additional technologies for that. MRI still is a great standard for our high-risk patients. We've been able to make that a standard of care for patients so that we're not fighting insurance for them and pre-authorizations. We still, though, have gaps there of, we have those intermediate risk patients or those patients who just want a little bit more of insurance to what is going on. So, the technologies I've talked about, it's a passion of mine of contrast enhanced. It's a mammography technology. It introduces vascularity. It helps you see where cancers may be developing earlier. And, we'll talk about it too, but as a rule out, it's a better diagnostic mammogram for women. And not to go back to the P's, but, we've talked about how women now, in a lot of areas, screening was considered non-essential. So they shut our systems down. And so women took it as okay, I don't have to go do this. Now that we're getting them back in, we need to keep them there throughout that care. Because one, they don't want to come back. Two, depending on their home life, they have kids at home, they're working from home, they may have lost their jobs. All of these things are affecting women in all households, but women particularly. So how do we get them in? And a lot of times, we come back to patient experience. It's such an important piece because now she is going through this alone. She does not have somebody there to help her, to listen, to understand. And we really need to provide, not the technical care, Roni, as you said, but that emotional and personal care too.
Fantastic. And, my takeaway from what you said, Celeste, was that, knowledge empowers us, it empowers women, it empowers outcomes, actually. And you talked about experience, but Roni, I guess experience is truly important from a process standpoint, but the rapid diagnosis is truly a step forward in terms of outcomes as well, and potential clinical outcomes too. Can you talk a little bit about your expectations of outcomes as we get through this rapid diagnostic process that we're talking about?
Yeah, some of the work that we've done here has identified, potential future measures that really could change the way the U.S. adopts this idea of, getting women in quicker. It's always an interesting process when you do a project like this. Providers tend to become creatures of habit because their schedules need to, manage their day, and they think about what they're going to get through in a day. And when you start to, help doctors, and in particular, look at process changes and think about what they would want to measure that's really meaningful, that helps them keep improving over time. Going through that exercise with the provider is always really fun. So we identified some really important and key core measures here that, St. Luke's has started to track. It certainly is, time to diagnosis. They're looking at feedback from patients that they get on a regular basis. They're looking at provider feedback that they're getting, the kind of energy it takes to go into a one-stop stay and how you rebound a physician's energy after that. They're looking at the way that the time for scheduling, they measure how much time it takes for a call to come in and then to get somebody scheduled on the books, access to scheduling and appointment times. So we have a suite of measures that we've really kind of talked through and thought about. And I think it's really important when you're chasing any kind of outcome measure, you need to also understand what your countermeasures are. You want to make sure that what you're doing, is good and doesn't cause a bad reaction somewhere else. And you also want to be thinking about the process measures that ensure that that outcome measure can be achieved as often and as commonly as possible. Make the process the habit so that the providers can do it in a way that allows them to be as efficient as they can. So we've had a lot of great conversations with the providers at St. Luke's, a lot of insights. I know Michele has learned a ton about, the capacity of all of the radiologists to, change up just their traditional day, and then what it takes to get all of the support staff to, go through the checklist in a meaningful, authentic, empathetic way so that they're doing the processes, they're maximizing what they need to create efficiency, but they're also at the same time making sure that the minute that woman walks in the door, she knows that she is cared for, not just being given care. It's really critical that you bring those things together. And that's what this model will help people understand and start to do at the beginning of their journey.
No, that's terrific, Roni. And Michele, just coming back to this point about outcomes, from a treatment standpoint, of course, that's when the improved outcomes can start. And if you have that treatment plan applied quickly, then you can start surgery if necessary. And it actually isn't always necessary. You can start therapy and intervention. We know that actually just a few weeks of delay between diagnosis and treatment can live to poorer outcomes. I guess from your perspective, from the clinical perspective, that's the goal here. Can you share a little bit more about your views on the goals in addition to that?
Absolutely. That kind of marriage with your surgical oncologist is so important. And really a linchpin in all of this process is the nurse navigator. Having those breast nurse navigators who are supporting that patient from that BI-RAD 0 callback through the surgical intervention and working, so closely, congruently with that surgical team. That is huge. That alone, we have seen with some of the health systems that we have acquired over the years, we've seen we're adding just the nurse navigator role has taken the radiology screening to pathology time from 28 days to 14 days in 1 month. 1 month. You can have that rapid a result and a such a positive impact for your patient. So now we're taking that methodology and we're working with that cancer care team and really looking at things more in partnership. Back in the day, when everybody was in one hospital, you could just go down the hall and talk to the surgeons. There are still some healthcare systems that have that benefit. More often now, we're seeing larger systems. There's been a lot of acquisitions mergers over the last few years nationally. So you don't always have that under one roof opportunity to just go down the hall. So relying on IT features like Zoom and Teams and, picking up the old fashioned phone, having those weekly breast care working groups so that both teams are just working in step together. That is a challenge that really can be supported by the nurse navigator.
Thanks, Michele. And look, in terms, I'll kind of come back to you, Celeste, because you alluded to a really important point, I think, around women not necessarily getting their screening mammograms, and oftentimes not being able to follow up the diagnostic exams. I guess that's one of your key interests, right? Just making sure that patients don't get lost in that process. Is that right?
Yeah, I think that's the biggest part of the whole rapid diagnosis and one-stop clinic. And we've seen this around the world. You've worked with other sites, Ben, in France and Colombia, who are doing this and proven this model. Before the pandemic, we know 50% of women aren't getting their mammograms. We don't want to look at what the numbers are today, but we know it's got to be worse. The other part that is, again, the opportunity to lose patients in the system is, approximately 40% of women don't even come back for their diagnostic workups.
Wow.
So you talked about that delay. Dr. Diaz from Colombia mentioned specifically every 3 months, which is not a long time in the cancer care world or breast screening world, cancer severity, the outcomes are worse, as much as a full stage each 3 months. So that, not only affects your treatment plan, it affects survivability, it affects the quality of life. And we know women should not be dying of cancer. If we find it earlier, the survivability is, I don't know, Michele, 100%. But I think, my expectation of the one-stop breast clinic in the US is to provide that opportunity for women, not lose them in the system, and do have those better clinical outcomes. And unfortunately, we just saw about a month ago, breast cancer surpassed as the #1 diagnosed cancer in the world. Mm. So it's a, frightening reality of what we're into.
And Celeste, when you talk about losing the patient, you think about that nurse navigator who has that roster of patients, right? She's got that work queue. But then you also look at treatments or tests like the contrast enhanced. You can start to really attack that BIRAD3 population that is on that, 6-month follow-up merry-go-round, because we just can't rule out right away. And so you keep with that follow-up. But something like that really helps to take that list and trim it down. And you start to move those women back to screening mammogram.
Right. And they start to trust the system again, and into that cost and access and time, and reducing that. Yeah, it's a great point, Michele.
Thank you. So look, as we close out, what's just shone through with all of you talking here is in this sort of choose to challenge that we've talked about. You guys have taken the choice, if you like, to challenge ourselves to do better for our women. Closing thoughts, maybe, I don't know, Roni, maybe start with you around that choice. What is your kind of final word on the choose to challenge I guess?
Yeah, thank you. I think 2 things I really want to put out there. The first is that, we in healthcare, we want to rely on all the evidence and feel strong about it before we kind of start to make changes. And I want to challenge everybody here to say that it's not an either or, it's an and both. There is evidence that exists, and there is innovation that can happen. It can happen fast. So it's a perfect marriage that, rapid cycle testing theories can help a rapid diagnostic, intervention. I think that this project proves it better than a lot of projects can, but don't be afraid to try something, because not trying something just means that we're delaying this important care. And the other point that I would make in terms of this last thing that we were just discussing, the importance of individualized breast care is so incredibly meaningful to advance the ability to care for patients. But when we talk about trying to get people to understand how to get in and get their screen and manage the access to appointments, et cetera, that's more of a population health strategy. So, oncology traditionally has been very focused on sort of individualized care because of genomics, et cetera. Totally important, completely get that. But getting to that point, it's about population health management. It's understanding how to identify a population at risk, even if it's early risk, and making sure that you're able to, manage that so effectively that you reduce the poorest outcomes that you don't ever want to have to tell a patient that they're facing. So I think that it's an opportunity for oncology in particular to really think about taking on this idea of population health management with individualized genomic care and marrying it up so that this rapid innovation really can happen. And I just appreciate being a part of this project with these great ladies and you too, Ben. So
thanks, Roni. I do too. Celeste, maybe your final word on your choice to choose to challenge.
Yeah, so we've been talking about it all along. So, we have the technologies, to Roni's point. We know the personal aspect, the population needs, and we know the science. So, we need to choose to challenge ourselves for a better standard of care for all women. And it's choosing that intent. And I just, I'll leave it there to have us all challenge that intent.
Thank you, Celeste. And the final word, Michele, is one at the patient-facing side of things. Tell us your final word on choose to challenge.
Choose to challenge yourself to do better. You're really taking an honest look at where you are today. We can all look at the best of our stats and the best patient feedback and believe we're doing a great job. And we may be, but we can do a better job. There's trying to get to 100%, which is not possible, but we're going to try to get to 100% of the time that these patients are getting rapid diagnostic results, that we are truly able to reduce their anxiety. A quick story. I've always told the team our silent goal is that we look at every single patient that's coming through the diagnostic center, and particularly those patients now that we're recommending a biopsy. And we have to think in our mind that mom or grandmother is now leaving our facility, driving to the bus stop to pick up children and put them in her car. So in what emotional state is she leaving the building? Mm-hmm. And last year we added to that story. We said now that patient, she also put her husband on hospice that morning because we had that patient. We don't know the level of emotional state that what people are dealing with. And so looking at every single patient individually, not only providing their individual clinical care, but supporting them individually to what their needs are. Some patients want to be completely left alone. You got to read that. Other patients want you to hold their hand and be with them, like physically touching them the whole time. And being able to read and support that patient how they need it. But getting to that result, we can all do better. And it's hard. If you're a high functioning team, you're already a 7 or an 8, it's hard to get to a 10. But everything we do, we can improve on.
Wonderful. Listen, let's close there. Celeste, Roni, Michele, thanks so much for your commitment to your roles, to women, to the concept of choosing to challenge when it comes to helping improving women's health. Thanks also for the work that you've done to implement rapid diagnosis to drive those health outcomes. And thank you for developing those new technologies, which have been critical and will be critical to come in the years ahead for care improvement. And to everyone out there who's listening, please don't panic. Please do some purposeful planning, as Roni said. Don't skip, but choose to challenge as well. So thanks for your time, thanks for your attention, and we look forward to speaking to you again soon. Thank you, and goodbye.